Hello everyone. Today we will have our Saturday Zoom meeting. So the green team and Maya will start the meeting. I will turn it to you. Go ahead when you are ready.
Yes, Dr. Nader. So hi everyone. Today our green team is going to present meeting, and our first agenda for today, stroke and cerebrovascular disease, is going to present by Dr. Afrah and Dr. Yassen. And Dr. Afrah, when you're ready, please share your screen. Thank you.
Thank you, Dr. Maya. Hello everyone. I hope you're doing well in your areas of application. All the best to you all.
Thank you so much, Dr. Afrah. Same to you.
Thank you. Can you see my screen?
Yes, Dr. Afrah.
Okay. So today we'll talk about the stroke and cerebrovascular disease. The objective of this session to be able to know or describe the impact of cerebrovascular disease on older adults, to know the treatment of acute ischemic stroke, to know how to recognize a transient ischemic attack, and to describe the prevention of ischemic stroke, prevention and treatment of hemorrhagic stroke. Topics covered in this session. First of all, we will talk about the impact of cerebrovascular disease. We'll talk about ischemic stroke, either due to small vessel disease or large vessel disease or cardioembolic and cryptogenic stroke. We will talk about treatment of acute ischemic stroke. We'll talk about TIA, primary and secondary ischemic stroke prevention. Also, we'll talk about hemorrhagic stroke in all types like intracerebral hemorrhage, subarachnoid hemorrhage, and subdural hematoma. First of all, impact of cerebrovascular disease. Incidence of stroke increases with advancing age, approximately double each decade. It's the leading cause of disability and death among older adults. 6 months after stroke, in those more than 65 years, 26% are dependent in their daily living activities, including dressing, eating, and getting in and out of the bed. And 46% have measurable cognitive deficits. Fatality rate within 1 month of an acute stroke is 20 to 30% across all age groups. Common medical causes of death associated with stroke are MI, arrhythmia, heart failure, aspiration, pneumonia, and pulmonary embolism. First, we'll talk about ischemic stroke, and my colleague will talk about hemorrhagic stroke. Ischemic stroke caused by occlusion of cerebral blood vessel. It accounts for approximately 80 to 85% of strokes. Knowing the cause helps guide treatment and prognosis. About 27% are due to cardiac emboli. So the major causes are cardiac emboli. About 90% are due to large vessel disease. 70% are due to small vessel disease, but 35% cannot be classified. We'll start with small vessel disease as a cause of ischemic stroke. It causes occlusion of small penetrating vessels due to lipohyalinosis, lipid deposition and hyalinization, or local arteriosclerosis. It causes ischemic stroke that are typically less than 1 cm, which termed lacunar infarcts. So whenever we mention lacunar infarcts, we mean the type of infarct that doesn't associated with higher level of symptoms like, cortical symptoms like aphasia, agnosia, and loss of consciousness. Risk factors are hypertension, diabetes, and smoking. Lacunar strokes can occur concurrently with other mechanisms of ischemic stroke. It can be presented with different presentation, like pure motor stroke or pure sensory or ataxic hemiplegia. Other cause of ischemic stroke, large vessel disease, most commonly caused by atherosclerosis, which can cause progressive occlusion of cerebral vessels in the anterior and posterior circulation. So the presentation will be depend on type of vessel involved, either anterior cerebral artery or middle cerebral artery. Can be identified by non-invasive imaging of the carotid arteries, either Doppler ultrasound, CT angiography or MR angiography, or conventional angiography. Risk factors include hypertension, hyperlipidemia, diabetes, and smoking. Cardioembolism also is an important, potentially preventable cause of ischemic stroke. AFib is the most common cause, which associated with a 4 to 5-fold increased risk because of thrombus formation in the left atrial appendage and cardioembolism to cerebral vessels. Cardioembolic stroke due to atrial fibrillation accounts for 25 to 30% of all ischemic strokes. Cardioembolic stroke often occurs without preceding TIA. Cryptogenic stroke is a type of ischemic stroke that does not have a clearly identifiable cause. Use brain and vascular imaging to assess the size of the vessels involved. Consider atypical causes of stroke, such as vasculitis, coagulopathy, mitochondrial disorder. You need to do prolonged cardiac monitoring. Is sometimes needed to capture intermittent AFib as a potential cause of cryptogenic stroke. So, immediate treatment of acute ischemic stroke. First of all, we should rule out hemorrhagic stroke by doing non-contrast CT scan. Then, we assess the severity and pattern of neurological deficits using NIH Stroke scale. Then, we identify non-stroke causes of acute neurological dysfunction like migraine, seizures, and drug intoxication. This NIH Stroke scale, our colleague will talk about it in details in the second topic, but in brief, it is a type of a scale that identify severity of neurological impairment in those who have acute ischemic stroke. It has 11 items, score from started from 0, in which 0 means normal neurological function. The overall score, if it is less than 5, suggests very good prognosis. If it is more than 20, suggests very poor prognosis and high risk of major complications, including death. Acute care of the older stroke patients. First of all, we optimize hydration status gradually to prevent cerebral edema. We should control blood pressure while avoiding hypotension. The concept here is called permissive hypertension, in which we should, our goal is to decrease blood pressure 15% in the first 24 hours, and then we keep blood pressure above 160, systolic blood pressure above 160. But also we should keep blood pressure less than 185 over 110 if the patient receiving alteplase. Also, we should prevent DVT. We detect and treat coronary ischemia, heart failure, and cardiac arrhythmias. We also start long-term antiplatelet therapy or oral anticoagulation. We can start antiplatelet therapy after 24 hours if we give alteplase. Also, we can start oral anticoagulation in patients who have non-valvular AFib within 7 days after acute stroke, especially if they started alteplase. Normalize body temperature and blood glucose. Also, there is an important thing here. We should evaluate for dysphagia in order to prevent aspiration pneumonia before we introduce any oral intake. The treatment usually recombinant tissue plasminogen activator, which is alteplate, but we should consider two things. First of all, we should rule out intracerebral hemorrhage by doing CT scan without contrast, and the patient should present within specific time window, which is usually 3 to 4.5 hours. American Hospital Association recommendation prolongation of the window to 3 to 4.5 hours for patients less than 80 years old who have NIH score less than 25 and no prior history of stroke or diabetes. We should require careful assessment by a clinician experienced in treatment of stroke. So we give alteplase after we rule out hemorrhage. We should carefully assess this patient in order to weigh the risk and benefit of giving alteplase. For the patient at risk of hemorrhage, we should not give alteplase. It carries a 66% risk of intracerebral hemorrhage, usually among patients with severe strokes. Contraindication to alteplase: major surgery within the previous 2 weeks, previous intracranial hemorrhage, systolic blood pressure more than 185 or diastolic more than 110, symptoms of subarachnoid hemorrhage, recent uncontrolled bleeding, coagulopathy, thrombocytopenia, and INR more than 1.7. There are other evidence-based intervention for those who have acute ischemic stroke, which is a combination between recombinant tissue plasminogen activator, alteplase, and endovascular thrombectomy. In 4 recent randomized clinical trials, endovascular thrombectomy in patients with proximal large vessel occlusions of the anterior cerebral circulation provided significant benefit when treatment began within 6 hours of stroke onset. Most patients received alteplase given IV before endovascular thrombectomy. Benefits were seen at 24 hours with 50% reduction in NIH score, at 90 days with improvements in functional outcomes. Transient ischemic attack, defined as a brief episode of neurological dysfunction caused by focal ischemia to the brain or spinal cord that does not result in acute infarction, traditionally thought to last up to 24 hours. Neuroimaging makes it clear that TIA typically lasts less than 1 to 2 hours. Longer episodes are commonly associated with acute infarction. It's the major risk factor for subsequent stroke. Management following transient ischemic attack. Transient ischemic attack symptoms should be evaluated emergently. Brain imaging, ideally with MRI, is important to determine whether there has been an acute stroke and, if one is found, its location and type. Non-invasive imaging of the carotid arteries, EKG, and echocardiography are important to determine the most likely cause of ischemia. Initiate treatment for secondary stroke prevention based on the results of the evaluation. So, preventing ischemic stroke. We know that the most important risk factor for ischemic stroke is hypertension. So in order to prevent ischemic stroke, we should monitor and control blood pressure. The goal is to maintain systolic blood pressure less than 140/90 for secondary stroke prevention and for primary prevention in those with other risk factors such as diabetes. Other risk factor is hyperlipidemia, so we should give statin therapy for primary prevention in patients estimated to have a high 10-year risk of cardiovascular events based on AHA guidelines. High intensity statin therapy for patients who have had a TIA or stroke believed to be of atherosclerotic origin, regardless of the LDL-C levels. Several studies have confirmed a 2 to 4-fold increased risk of stroke in individuals with diabetes mellitus. Aggressive treatment of hypertension and hyperlipidemia in the diabetic population is crucial. Some research suggests that tight control of blood glucose levels in healthier adults with diabetes might reduce the risk of stroke, although the evidence for reduction of other vascular complications like microvascular complications like retinopathy and nephropathy is more compelling. So in brief, in those who have diabetes, we should control other risk factors that lead to stroke, like associated hypertension, associated hyperlipidemia. And also we can do tight control blood glucose, which might help in reduce the stroke and other microvascular complication. The third risk factor, which is smoking, support cessation of smoking, which increase the risk of stroke as much as threefold. Long-term oral anticoagulant therapy is recommended for patients with valvular and non-valvular atrial fibrillation at high risk of stroke and low risk of hemorrhagic complications. For valvular atrial fibrillation, warfarin dosed to a target INR of 2 to 3. For non-valvular AFib, first-line options are warfarin with INR 2 to 3, or apixaban, edoxaban, or rivaroxaban with dabigatran as an alternative. Consider aspirin for patients with non-valvular atrial fibrillation and low risk of strokes. If possible, initiate oral anticoagulation within 14 days of the TIA or stroke in those with atrial fibrillation. Following non-cardioembolic ischemic stroke, aspirin is the mainstay of antiplatelet therapy for secondary prevention. The minimal necessary dosage has not been determined. Other antiplatelet medications have not shown consistent superiority to aspirin. Sustained release bridamol combined with aspirin, clopidogrel, but it's an option for patients who cannot tolerate aspirin, combined clopidogrel and aspirin. So aspirin is the mainstay antiplatelet therapy for secondary prevention of stroke. In two large trials, no benefit was found for the use of warfarin over aspirin for secondary prevention in the setting of large vessel disease, including intracranial atherosclerotic disease. Dr. Yassen, you can continue.
All right, I'll continue. Are you going to still share the slide or?
As you want. Do you want me to?
No, it's fine. It's fine. I can share mine.
Okay.
Okay, can you guys see my screen?
Yes, Dr. Yassen.
All right. Okay. So I'm going to be talking about managing ischemic stroke. So first, all patients with cerebral atherosclerotic disease target modifiable risk factors, prescribe daily antiplatelet agent and statin. Patients with more than 70% symptomatic carotid stenosis, they will need to have carotid endarterectomy. Patients with recent TIA or ischemic stroke and ipsilateral moderate 50% to 69% carotid stenosis will also need to consider carotid endarterectomy. Asymptomatic patients who have more than 70% stenosis of the internal carotid artery will also need to consider CAA or endovascular treatment with carotid artery angioplasty and stenting, but only if the perioperative risk of stroke, MI, and death is very low. So it has to be less than 3%. Next thing, I'm going to be talking about treating cryptogenic stroke. So first, we need to evaluate and treat the modifiable stroke risk factors and initiate antiplatelet therapy. If a cardioembolic cause is suspected, then prolonged, for example, 30 days, cardiac rhythm monitoring for AFib is reasonable. And oral anticoagulant therapy should be initiated if intermittent if AFib is found. In the setting of patent foramen ovale and venous source of embolism, oral anticoagulation is recommended. If anticoagulation is contraindicated in such a patient, then an inferior vena cava filter or transcatheter PFO closure can be considered. Next thing, I'll be talking about intracranial hemorrhage. So it accounts for about 15% to 20% of all strokes. Four main subtypes: intracerebral hemorrhage, subarachnoid hemorrhage, subdural hematoma, and epidural hematoma. So it presents with abrupt onset of focal neurologic symptoms, it often associated with severe headache, vomiting, very high blood pressure, and coma or decreased level of consciousness. It carries a higher risk of mortality than ischemic stroke and is best treated in comprehensive stroke centers. Emergent brain imaging, such as head CT scan, is needed to determine whether a stroke has hemorrhagic or ischemic. Also, in the intracerebral hemorrhage, the patient's blood pressure, the systolic blood pressure of 150 to 220. So we need to lower it. We need to lower the systolic blood pressure to 140. Patients who are on warfarin, intravenous vitamin K, and therapy to replace vitamin K dependent clotting factors to normalize the INR to the normal levels. Patients with severe coagulation factor deficiency or severe thrombocytopenia, factor replacement therapy or platelets as needed. And for all anticoagulant and antiplatelet therapy should be stopped in acute period. When it comes to management of intracranial hemorrhage, we need to control the blood pressure at first. So the systolic blood pressure needs to be lower than 130, and the diastolic blood pressure needs to be lower than 80. In patients at high risk of future ischemic cerebrovascular events, such as those with mechanical heart valves and prior ischemic stroke, anticoagulation may need to be restarted within 2 weeks of the hemorrhage. And in all others, withhold oral anticoagulation for at least 4 weeks to prevent recurrent hemorrhage. The next type is subarachnoid hemorrhage. So it is usually caused by a rupture of an intracranial aneurysm, 80 to 85% of cases, or another abnormality of a cerebral vessel, examples such as atriovenous malformation. Risk factors of rupture. First is the size of the aneurysm, the age of the patient. The older, they're more prone to have an aneurysm, female gender, posterior circulation location, enlargement of the aneurysm over time, and a prior subarachnoid hemorrhage. Patients with an aneurysm at high risk of rupture should be referred to a neurosurgeon. Acute management of subarachnoid hemorrhage is similar to that of intracranial hemorrhage, but it includes surgical intervention and focuses on detection and treatment of atrial vasospasm as it would be a common complication. Subdural hematoma, it is defined as a collection of blood between the dura and the arachnoid, usually due to head trauma. Usually the trauma might be mild, particularly in older adults. Bilateral in approximately 15% of cases. Some older adults suffer from chronic subdural hematoma that may be symptomatic. As we can see here, it shows us the incidence per 100,000. And as we can see, that the older population are at a very higher risk compared to the younger population. And as we can see here, with no history of head injury, that's mostly 50% of the cases. And other risk factors are clotting disorders, shunting procedures, and seizures. So the symptoms of chronic subdural hematoma, usually the patient would have headaches, slight to moderate cognitive impairment, focal neurological signs, example, hemiparesis, hemisensory loss, depending on where the bleeding is at. And some individuals develop seizures with or after a subdural hematoma. So symptomatic and the patient's condition is worsening. So in that case, what we need to do is we need to remove the clot because that's usually what makes the symptoms become even worse. In patients who are asymptomatic and they're improving, clinical monitoring is appropriate because the hematoma may resolve without surgery. So there is a recommendation that is that was being done by the American Board of Internal Medicine Foundation called Choosing Wisely. It says that do not recommend carotid endarterectomy for asymptomatic carotid stenosis unless the complication rate is less than 3%. So in summary, cerebrovascular disease is a leading cause of disability and death among older people. Acute stroke treatments can effectively improve outcomes in patients, especially when care is provided soon after stroke symptoms begin and in a multidisciplinary stroke center. Primary and secondary stroke prevention can significantly decrease the burden of cerebrovascular disease in older population. So we have our first case. It is a 79-year-old woman has palpitations and shortness of breath. There is no history of cognitive difficulty or bleeding diathesis. Last winter, she fell on icy steps. Examination shows irregular heart rhythm and no murmur, no evidence of valvular disease. And on her EKG, there is a new onset of atrial fibrillation. Her heart rate is 78 beats per minute, and her creatinine is 1.6. So the question is, which one of the following is most important to consider before or during anticoagulation for this patient? So what do you guys think? Oh, sorry, my bad. Okay, I see the answers. There's B, C, C. And anyone else? Okay. All right. Let's go. Let's check the answer. So the answer is C, her renal function. All right, so the second case is an 88-year-old woman has sudden onset of deafness in her right ear, accompanied by intermittent episodes of dizziness, during which the room spins very quickly. Symptoms began 2.5 hours ago. She has fallen twice since symptoms began, and she has walked into walls. Her history is coronary artery disease, hypertension, cervical spine degenerative disc disease. She has no history of stroke, TIA, or diabetes. Her medications are aspirin, statin, and antihypertensive agents. She lives independently, uses a cane, and drives. Which of the following would be the most appropriate first step? Is it A, to obtain an audiogram, or B, to obtain otolaryngologic evaluation, or C, obtain urgent CT of the brain, or D, prescribe mechanism? All right, so everyone is answering C. So we can check the answer. Correct. The answer is C. We need to obtain a CT scan of the brain. So we're gonna do the third case. It talks about a 90-year-old woman comes for a follow-up 1 week after discharge from the hospital, where she was treated for a right 1 centimeter basal ganglia subcortical hemorrhage. She is accompanied by a caregiver from the facility where she received PT and OT. Blood pressure on arrival at the hospital was 220 over 106 or over 106. At today's appointment, the caregiver reports that she tends to be sleepy, difficult to arouse in the morning, but is otherwise doing well. Her appetite is good. She has no loss of consciousness, seizure-like activity, or headaches. There has been improvement in left-sided weaknesses. Her history is significant for coronary artery disease, hypertension, remote MI. She had been a heavy cigarette smoker, but quit 24 years ago. Her medications are in the last 6 months before hospitalization. She had been progressively forgetful and may not have taken her medication as prescribed. Her medication list is aspirin, levetiracetam, amlodipine, chlorthalidone, and metoprolol. During her examination, her blood pressure was 116 over 86, and her heart rate was 60 beats per minute, and it was regular. So the question is, which one of the following is the most appropriate next step in management? Is it A, to discontinue aspirin, or B, to decrease metoprolol dosage to 25 milligrams per day, or decrease levetiracetam dosage to 500 milligrams per day, or discontinue levetiracetam at all? So the answers. Okay, so the first answer is A. Anyone else? All right, second answer is B. Anyone else? B. All right, I'm gonna check the answer. So the answer is to discontinue levetiracetam. All right, do you guys have any questions? This is the end of our presentation.
Thank you, Dr. Afrah. Thank you, Dr. Yassen.
Yes, thank you.
For a nice presentation. Yes, any question from this agenda? Okay, Dr. Nader, should we proceed further?
I guess.
You can go to the next. Thank you so much for the presentation. Excellent presentation. Thank you.
Thank you.
Great work.
Thank you.
Okay, so second agenda of today's meeting is NIH Stroke. It's going to be presented by Dr. Telal, Abass, and Dr. Sulafa. Okay, Dr. Telal and Dr. Sulafa, when you are ready, please share your screen. Thank you.
Hi, thank you, Dr. Maya. Thank you so much, Dr. Nader, for giving us the opportunity to present today. Thank you, Dr. Maya, for your hard work for this presentation. Thank you all for your time. I'm going to share my screen. Can you see my screen now?
Yes, Dr. Sulafa.
Yes, and I'm sorry I have hard time to open in full screen. So my name is Sulafa Elhassan, and I'm going to present today on NIH Stroke scale. So administer the stroke scale criteria in the specified order. So when you have a patient and you want to evaluate this patient, you should follow the specific order of the evaluation. After passing each subscale exam, note your result in each category. So like there is a sheet and there is a parentheses. You can write your notes and your results in that inside the parentheses. Do not go back and adjust the result. consider the guideline offered for each exam technique. There is, for example, a booklet from the NIH. You can read this guideline and follow it during your examination. And later on, I will share with you the booklet and the exam sheet. Okay, then score should be passed on the patient performance, not what the clinician believes the patient is capable of. So if you think, for example, this patient is tired, this patient have anemia, he cannot do or cannot perform this. So do not report result according to your evaluation. What the patient did, just take it and put it in your report. So while giving the retest, the doctor should immediately record the response. So for example, during many encounters, you can come, evaluate the patient, take the history, do the exam, and go outside, then report what you have seen. But here, you should write it immediately and record your response immediately. The patient should not be coached unless necessary. So don't for example, perform the test in front of the patient unless this is necessary. So then we will start with the scale. So when to evaluate the level of consciousness, the investigator must choose a response. If a full evaluation is prevented by obstacles such as endotracheal tube, language barrier, or tracheal trauma bandage, so you try your best to just do the evaluation and give the best score you can, like the best evaluation of the score you can do. 3 is scored only if the patient makes no movement other than reflexive posturing in response to nauseous stimuli, like the gag reflex or nauseous stimuli. So you can put here 3. And if you can see my notes here, this is the key for reporting. 0, alert, nearly responsive, when not alert but arousable by minor stimulation, like if you start to talk to him or you put just touch to his leg, his arm, and he start to respond, then you can give him 1 point. 2, not alert, require repeated stimulation to attend. And give 3 if he responds only with reflex motor or autonomic effect of totally unresponsive, flaccid, or the patient was reflective. Also, levels of consciousness question, you can ask the patient about the month or his or her age. And when you take this answer, it should be the exact answer what you have in his medical record. So if he was so close February instead of March, you not give like when for him. So this should be the exact what you have in the patient record. Sometimes the patient will be aphasic or stuporous. He cannot comprehend the question, and you can score him 2. Patient who cannot able to speak because of endotracheal intubation, orotracheal trauma, or severe dysphagia from any cause. So, for example, sometimes even language barrier could be barrier to understand you and talk to you, or any other problem like aphasia, you can give the patient 1. It is important that only the initial answer be graded and that the examiner not help the patient with verbal or non-verbal cues. So even we shall not try even to help him with the sign language or any cues. And here also the key 0, if the answer is 0 for both question correctly. So sorry, if the patient answer both question correctly, we will give him 0. If answer 1 question correctly, we will give him 1. And if he didn't answer one of the questions, so we'll give him 2. We have also level of consciousness commands. The patient is asked to open or close the eyes and then the grip and release the non-paretic hand. Substitute another 1-step command if the hand cannot be used. So for any reason, if there is fracture, any reason you cannot use the hands, you can substitute any other 1-step command. Credit is given if the univocal attempt is made but not completed because of the weakness. If the patient does not respond to the command, the task should be demonstrated to him or her, and the result should be scored. Sometimes you have patient with trauma. amputation, or other physical impediment should be given suitable one-step command so you can evaluate his response. And also the key for this test, 0, if he performed both tasks correctly, 1, if he performed one task correctly, and 2, if he cannot perform either of the tasks. Then we will come to the second part of the evaluation, which is the best gaze. So only the horizontal eye movement will be tested. Voluntary or reflexive, which is oculocephalic eye movement, will be scored, but we will not do the caloric testing in this patient. If the patient has a conjugate deviation of the eyes that can be overcome by voluntary or reflective activity, we'll give him the score of 1. If the patient has isolated peripheral nerve paralysis like cranial nerve 3, 4, or 6, we'll give him a score of 1. So gaze is testable in all aphasic patients. Patient with ocular trauma, bandage, pre-existing blindness, or other disorder of visual acuity or fields should be tested with a reflexive movement, and choice made by the doctor whether he will give him the score of 1 or 2. Establishing eye contact and then moving about the patient from side to side will occasionally clarify the presence of partial gaze palsy or not. And the key of this case, we will give, if the best gaze was normal, we'll give 0. When if there is partial gaze palsy, gaze is abnormal in one or both eyes, but forced deviation or total gaze paresis not present, and we'll give 2 if forced deviation or total gaze paresis not overcome by the oculocephalic maneuver. Okay, the next step to do the visual fields, upper and lower quadrant. We tested them by confrontation using finger counting or visual thread as appropriate. The patient may be encouraged, but if they look to the side of moving finger appropriately, this can be scored as normal. If we notice that there is unilateral blindness or inoculation, visual field in remaining eye are scored. So we'll give score 1 only if clear-cut asymmetry, including quadrantopia, is found. So if we find quadrantopia, then we'll give 1. If patient is blind from any cause, so we'll give score 3. Double stimulant stimulation is performed at this point. And the key for that, 0, no visual loss, 1, partial hemanopia, 2, if there is complete hemanopia, and 3, if there is bilateral hemanopia. So this is if the patient blind, including cortical blindness. So regarding the test for facial palsy, ask the patient to show teeth or raise eyebrows and close eyes. Score symmetry of grins in response to noisy stimuli in poorly responsive or non-comprehending patient. If he's not comprehending, try this maneuver to see the response in the face. If facial trauma, bandages in orotracheal tube, tape, or other physical barrier obscure the face, this should be removed to the extent possible, like no harm for the patient, and then we can assess the facial palsy. And the key for this test, 0 normal symmetrical movement, 1 minor paralysis like flattened nasolabial folds, asymmetry on smiling. We'll give 2 if there is partial paralysis, total or near total paralysis of lower face, 3 if there is complete paralysis of one or more or both sides. So this all what I have for today. Dr. Telal will continue the talk, and please feel free to unmute yourself if you have any question.
Thank you, Dr. Sulafa.
Hello, everyone. I will continue the NIH stroke scale. Number 5 here, we have the motor arm. The limb is placed in the appropriate position with extending the arm at 90 degrees. If sitting or 45 degrees, if it's supine, the drift in the arm should be for arm before 10 seconds, not like the lower limb in 5 seconds. The aphakic patient is encouraged using urgency in the voice and pantomime, but not noxious stimulus. Each limb is tested in turn, beginning with the non-paralytic arm. It means you have to examine the not paralytic arm. Only in the case of amputation or joint fusion at the shoulder, the examiner should record the score as untestable and clearly write explanation for this choice. Down here, we have the key for that. 0, we give 0 for non-drift limb. As I mentioned, for 90 degree or 35 degree for full of 10 seconds. I give the patient 1 if it has a drift, limb hold, or drift between before the 10 seconds. I give him 2 if he has effort against gravity, okay, but he cannot get or maintain a 90 or 45 degree. I give him 3 if he's no effort against gravity, and 4 no movement, and untestable if he has amputation or joint fusion. Motor leg. The limb is placed in the appropriate position. We hold the leg at 30 degree. For always tested supine. As I mentioned, the drift scored if the leg fell before the 5 seconds. The aphakic patient is encouraged as at the motor arm. Also, I have not, I can't examine the paralytic limb, okay? And also here, we the amputation joint or fusion joint hip, I have to score it as untestable. The key score here, it is similar to the arm, motor arm. Also 0 for no drift, or leg held for 30 degree position for full 5 seconds, not 10 seconds like the Afrah. 1 if it's a drift, that means the leg fall by the end of 5 second period, but does not hit a bed. 2, some effort against gravity. 3, there is no effort against gravity. 4, no movement. And untestable if there is imputation. Limb ataxia, number 7 here, limb ataxia. Usually, if the patient he has a visual defect, we examine the patient with finger, and heel chain test are performed in post-eye. And ataxia is scored only if the present out proportion to weakness. Ataxia is absent in the patient who cannot understand or is paralyzed. Only in case of amputation or joint fusion, the examiner should record the score untestable as motor limb and also here the key for that: 0 for absent, 1 for present in one limb, 2 for present in 2 limbs, and UN for amputation or fusion. Sensory. After the first history and examination, I have to exclude the patient. He has previous sensory loss, because here in NIH Stroke, I have to find the new sensory impairment due to stroke, not the previous sensory loss. And I have to examine the arm, the hand, and also the trunk by the pinprick sensation. And the key for my examination, it is if it is normal, I will give him 0. If mild to moderate sensory loss, I will give him 1. And if it is the severe to total sensory loss, I will give him 2. The best language, number 9, the best language. I have to ask the patient to, for example, to ask him about the picture or about the name. And if the patient is blind, okay, I will give him some subject or object to identify by him by his hand, and to see to identify this object. For example, here they said for the scale item, the patient asked happening attach a picture to name the items, attached naming sheets, and to read from the attached list of sentence. Comprehension is judged from response here, as well as all commands in the preceding general neurological exam. If visual loss interfere with the test, ask the patient to identify object placed in the hand, repeat and produce speech. The intubated patient should be asked to write. The score, the key score here, 0 for if there is no aphasia. That means normal. 1, mild to moderate aphasia, or some obvious loss of fluency. And 2, if there is severe aphasia. This Afrah, if the patient is thought to be normal, and an adequate sample of speech to be obtained by asking patient to read or repeat word from attached list. In the patient has a severe aphasia, the clarity of articulation of spontaneous speech can be rated. Only if the patient is intubated or has other physical barrier to reducing speeds, the examiner should record the score as untestable. They mention also, don't tell the patient why he or she is being tested. The key here, 0 for normal, 1 for mild to moderate dysarthria, and 2 for severe dysarthria. In the website, or the link given by Dr. Nader, there is a good sheet, okay? All these steps, it is clear here, okay? And also there is one place for the score and how to do this evaluation for all the steps. And I think it is very helpful because, you know, no one can memorize all this information because, you know, it is prognostic scale should be accurate and complete. And as mentioned by Dr. Sulafa, the doctor should be follow the structure and to go regularly for that. Here the picture, when the patient he can identify the objects or the action of the people here, and here's some sentence to repeat it, to also to examine the dysarthria, and thank you if you have any question.
Thank you so much, Dr. Telal and Dr. Sulafa. Yes, anyone have any questions? Okay, so next agenda of our today meeting is MD calculator as a tool is going to be presented by Dr. Rawia. Dr. Rawia, please share your screen when you free, when you available. Yes.
Hi, Dr. Nader. Hi, everyone. Thank you, Maya, for coordinating this meeting.
You're welcome.
Okay. So my presentation is MDcalc as a tool to calculate different medical scores. MDcalc is an application that created in 2005. And since then, it has served as a top source for medical information on the most current, popular, and relevant clinical calculators that support the provision of evidence-based patient care. This calculator app is created by board-certified physicians to be used by physicians, physician assistants, nurse practitioners, pharmacists, and medical students. It gives users access to 550 and more simple clinical decision tools, such as risk scores, equations, classification, dosing calculators, and more. The app includes concise summaries of studies relevant to the medical calculator, links to the studies on PubMed, perils and pitfalls, next steps, and expert commentary from the calculator's developers. The app clinical decision-making tools support over 35 specialties, such as cardiology, critical care, ICU, emergency medicine, gastroenterology, hematology, hepatology, infectious disease, and internal medicine. The following features make this app unique and ideal for use by clinicians. It works offline and in limited connection settings. It's fast and easy search, and it has fast and easy search and filter to discover new calculators. Customizable list for quick access, such as favorite, recently used, and your specialty. Auto-sensing between the website and the app. A quick toggle between United States and the international units. Error warnings and normal value to help avoid mistakes and improper inputs. The following are some of the tools provided by that app. The Hasbled score for major bleeding risk, CHATS2 score for atrial fibrillation stroke risk, the CHATS score for atrial fibrillation stroke risk, and this, when compared to the CHATS2, is better for low-risk patients. The CURB 65 score for pneumonia severity. So I need to share my screen for the. Can you see the main page for the calculator?
Yes, Dr. Rawia.
Yes.
So this is the main page for this app. And as you see here on this list, you can see the popular tools, the recent one used, the favorites, and you can add this by clicking on the star here on the right. And here, the specialty, the tool is divided by different specialty. Here's some guidelines provided by different association. And here you find all tools listed alphabetically. So I added some of the tools to the favorite to be easy access. We can go here to Hasbled score for major bleeding risk. It estimates the risk of major bleeding for patient on anticoagulation to assess risk benefit in atrial fibrillation care. Here you can find the creator of this score, Dr. Rampister. Here you can find when to use this score, the pairs and pitfalls for this score, and why to use it. The name of the score, each letter of the name is based on the variables used to calculate that score. So for this score, as you see here, you have hypertension, if it's uncontrolled, or more than 160 for systolic blood pressure, renal disease, dialysis transplant, creatinine more than 2.26 milligram per deciliter or more than 200 micromole per liter, and liver disease, cirrhosis, or bilirubin more than 2 times normal, with AST, ALT, AP more than 3 times normal, stroke history, prior major bleeding or predisposition to bleeding, labile INR, age more than 65, medication usage predisposing to bleeding, and alcohol use more than 8 times or equal to 8 times drinks per week. Each variable can add 1 to the total score. So if we have a patient who is like his age is more than 65, and let's say he hypertensive and his hypertension uncontrolled. So As we see here, the total score for this patient is 2, and you have the comment. What that means? Risk was 4.1% on one validation study, study done by Dr. Lip on 2011, and 1.88 plates per 100 patient years in another validation study that done by Dr. Pisser in 2010. The recommendation based on this score, anticoagulation can be considered. However, patient does have moderate risk for major bleeding. It's almost 2 per 100 patient years. So what's the next step? Patient-specific risk and benefits of anticoagulation must be carefully weighed in all patients who are potential candidates for long-term anticoagulation therapy. Here on the page, we have the evidence. It shows the different variables and the score for that. And here we have a table containing the score for the patient, what risk group he will be added based on that score, the risk of major bleeding based on that study by Dr. Lip, bleeds per 100 patient years by the other study, and the recommendation based on that. So the score of 0 and 1 put the patient on relatively low risk, and the recommendation would be anticoagulation should be considered. The score of 2 or 3 put the patient on moderate risk group. The anticoagulation can be considered, and this is as our patient here. The score of 4 or 5, this is a high risk group, and alternative to anticoagulation should be considered. The score of more than 5 is very high, and it's rare to determine the risk, but it's likely more than 10%. And here we can find the studies, the link for the studies, if you want to take a look on that. Here we have the creator inside. The creator answers some question regarding the score and what support the use of this score. We went back home. So we have this score, the charts, score for atrial fibrillation stroke risk. Same as that one. Estimated stroke risk in patient with atrial fibrillation. Here the name of the creator, Dr. Brian Page. Here's some information on when to use it, the perils and pitfalls, and why to use it. Those are the variables used to calculate this score. The history of congestive heart failure, hypertension history, patient age 75 years or more, and diabetes mellitus history. Each one of these variable added 1 to the score, and the history of stroke or TIA symptoms previously give the score of 2. So let's see. If we have a patient who is 75 or more, and he has a history of congestive heart failure, the score would be 2 points. This put the patient on intermediate risk of thromboembolic event, 4% risk of event per year if not accommodated. The adjusted stroke rate was the expected stroke rate per 100 person years derived from the multivariable model, assuming that aspirin was not taken. Okay, so this is a chart 2 score. We need to consider using CHATS-VASC score to patient with CHATS score of 0 in moderate to further risk stratify this patient. So the patient with low risk in this score need to be reassessed by the other score we will go through next. So for patients who are considered as moderate, like a score of 1 or 2 as our patient, or high risk of ischemic stroke, more than 3, anticoagulation therapy should be considered. So that what we get, or the recommendation from this score. Here we can find the evidence. Is also like the studies that support the use of this score and the recommendation for that. Here are some of the information about the creator of this score. I'm gonna go back. Through the CHATS-VASC score. It's a score for atrial fibrillation stroke risk. Calculate stroke risk for patient with atrial fibrillation, possibly better than the CHATS-2. As we mentioned that it should be used for the patient who scores 0 on that score to better assess his or her risk to have the stroke. So here we have the variables we used for this score. It's age, less than 65 gives a score of 0, 65 to 74, score of 1, more than or equal to 75 gives a score of 2. Sex for female, a score of 1, and male, score of 0. History of congestive heart failure, hypertension gives a score of 1. Stroke, TIA, thromboembolism history gives a score of 2. Vascular disease history, like prior MI, peripheral artery disease, or aortic plaque, give a score of 1, and history of diabetes give a score of 1 also. So let's say that we have 65, less than 65 male with like history of hypertension. So he has a 0.1 score. Stroke risk was 0.6 per year in 90,000 patients, the Swedish atrial fibrillation cohort study, and 0.9 risk of stroke, TIA, ischemic embolism. One recommendation suggests a 0 score for men or 1 score for women, which means no clinical risk factors except for the sex, is low risk and may not require anticoagulation. 1 score for men or 2 score for women is low to moderate risk and should consider antiplatelet or anticoagulation. And a score of more than or equal to 2 for men or more than or equal to 3 for women is moderate to high risk and should otherwise be an anticoagulation candidate. So these are the recommendations based on the scores by this tool. And same, we have here the next step, the evidence for using this score, and some creator decides to answer some question about the support the use of this score. I'm gonna go back again. For the last example we can use by this application, it's a CARB 65. A score for pneumonia severity. It estimates mortality of community-acquired pneumonia to help determine inpatient versus outpatient treatment. Here is a tip for COVID used after diagnosis to determine disposition with inpatient versus outpatient treatment may have some value in COVID-19. Those are the variables used to assess this or to calculate this score. Confusion, blood urea nitrogen more than 90 milligram per deciliter or more than 7 millimole per liter for urea. Respiratory rate more than or equal 30. Systolic blood pressure less than 90 or diastolic blood pressure less than or equal 60. Age more than or equal 65, which is score gives 1. We have here some question about the COVID. It will not affect the results. It's just for research. If we have a patient who is 65 and he has a respiratory rate of 30, we said, this put the patient on moderate risk, risk group, 6.8%, 30-day mortality. Consider inpatient treatment or outpatient with close follow-up. So this is what recommended by this score. You want to see here on the evidence. Okay. So here we have like a table, show the score for from this tool, the CARB-65 score, the mortality risk, and the recommendation that driven from certain studies. So if the patient has a score of 0, this gives him 0.6% mortality risk. And if he has a score of 1, the mortality risk will be 2.7%. Both these scores put the patient on low risk, and we should consider home treatment. A score of 2 gives a mortality risk of 6.8, short inpatient hospitalization or closely supervised outpatient treatment. A score of 3 gives a mortality risk of 14%, severe pneumonia, hospitalized, and consider admitting to intensive care. This as well as the score of 4 or 5, which gives a mortality risk of 27.8. So 3, 4, or 5 scores give put the patient on the category of severe pneumonia, and we need to hospitalize and consider admitting to intensive care. Another important information that every patient with high CARB score should be assessed for sepsis and septic shock. And there are some scores used for that. One of them is SIRS score to assess the condition of the patient. And I think that's it for me. If anyone has any comment, question, or addition, go ahead.
Thank you so much, Dr. Rawia, for a nice presentation.
Thank you, Maya. Thank you, everyone, for your time.
Any question?
Thank you so much again for this great presentation, and as the previous presentations, all excellent. Thank you so much.
Thank you.
If no questions, we can go to the next. And before that, I just want to share with you that it's important to understand the tool that we can use, and also the background and the literature behind that, or what the history when they started, what the development, and how they are using it nowadays. So it will help you when you see your patients. I have one patient when I was intense. My first couple of days I was in the ER, and I had a very good attending, and we had a patient who came with pneumonia. Although he was young, but he had some symptoms. So if we use a calculator that was calculated often, looking at pneumonia severity, at that time I did not know anything about the score of the tool or how to calculate the severity. So my attending was like, oh, this patient doesn't look good. And I was amazed by her assessment because she didn't spend a lot of time. I think she just looked at the vitals, looked at the patient, and then she gave him a bad prognosis. And a few hours when we started him from IV fluid and try to resuscitate and give antibiotics, he started to decline. So we sent him to the ICU right away. And by the next day, he passed away. So if you use this calculator, it will help you identify, I think, from the first look, what's going on with the patient and the prognosis. So if you want to act aggressively, you have the opportunity instead of waiting. Same with the other tools, the NIH and Stroke. These are very important. Thank you. Thank you to all presenters. Thank you. Thank you.
Okay, thank you so much, Dr. Nadir. And the last agenda of our today meeting is TED Talk is going to be presented by me. So let me share my screen. Everyone able to see my screen share?
No, not yet.
Now?
Yes.
Okay. Thank you so much. So today I'm going to present TED Talk. Actually, first I want to let you know what is TED Talk. TED is defined or stand for Technology, Entertainment, and Design. And TED began in 1984 as a conference where technology, entertainment, and design converged, and today cover almost all topics from science to business to all global issues. And it has been in more than 100 languages. And TED Talk is nowadays owned by one of the British, Sir Chris Anderson. He's a British American businessman who is the head of TED, a non-profit organization that provide idea-based talks and host an annual conferences in Vancouver, British Columbia, Canada. And who is the founder of TED Talk? Actually, the founder of TED Talk is Harry Marks and Richard Sol Verman. He's the founder of TED Talk. Next. So second one is why are the TED Talks 18 minutes or less? So TEDs are 18 minutes or less rule works because the brain burns energy, consuming lots of glucose, oxygen, and blood flow. As the brain takes in few information and processes it, millions of neurons are firing at once, burning energy and leading to fatigue. The research at Texas Christian universities are finding that the act of listening can be as equally draining as thinking hard about a subject. So Dr. Paul King called it cognitive backlog, like weight. And the more information we are asked to take in, the heavier and heavier it gets. On average, after 18 minutes, we drop it all actually. And falling to remember most of what we heard. That's why they are suggesting the talk should be less than 18 minutes. So this is why the talk curator Chris Anderson says 18 minutes is long enough to be a serious and short enough to hold people's attention. He adds, by forcing speakers who are using to going on for 45 minutes to bring it down to 18, we get them to really think about what they want to say. It is a clarifying effect. It brings discipline. For example, if given to me, for example, 18 minutes, I should precise everything. I cut down the things which are not necessary, not related to this topic. I put them aside. If I have 45 minutes or more than 1 hour talk time, so my topic will be very huge. That's why they are advising the talk should be less than 18 minutes. Then what makes a great TED Talk? So there are the 5 qualities that define the best TED Talk. First quality, you have first-hand personal experience, means which we are talking about anything, we first experience it. Second, your topic is new or niche. Third, you are tackling an old problem in a radical new way. Fourth, you have done groundbreaking research on topic you are presenting or any presentation. And fifth, you are solution oriented. First, we have to present it with one problem, and then we have finally solution of that problem. And then we have 5 elements of great TED Talk. First, begin with the end in mind. So basically, this is when we are talking about something, we must have clear idea about your central idea. Laser focus on a single concept will give a fine mesh filter for editing your material. Second, have a catchphrase. The best catchphrases are short and include a call to action. For example, think, yes, we can, or if it doesn't fit, you must quit. Then third one, avoid intro buzzkill. Like our intro must be very, very attentive so audience get attention. It must be interesting. Something we are going to present is something like in a question form or something like topic should be very good. So listener get attention. Number 4, open strong to hook your audience. The best opening, a personal story. We have to must first start with our story, a shocking statement, or powerful question. And number 5, retrieve the why. Find an opportunity to inspire your audience to change their perspective or call them to action. He highlights several ways to accomplish this, including shortening your sentences and give your audience an easy way they can take that next step. So there are many examples. When I read about this topic, there are so many examples available on a Google, and all examples are wonderful. I'm not able to decide which should I include in this presentation. But this one example I added in this is very good. Let's have a talk on this. How kids can design cities by Mara Manzar. So who is the Mara Manzar? Manzar, an urban planner, presents the problem at the beginning of her talk. She said, our society routinely makes decisions without consulting a quarter of population. Why she think about this? She's talking about children. And this is the truth. So obvious and striking that we wonder why we have never really thought about it before. Let's see. She shares her experience as a part of Growing Up Boulder, a city planning program that consulted children in a primary and secondary school on the development of a park. She encourages the audience by showing photos of children's idea for the park design. Towards the end of the talk, Manzar cited the belief of one city mayor that children are indicator of species. So everyone is looking at each other like how the children are indicator of species. So she said, if an area is comfortable and accessible for them, chances are they are also comfortable and accessible for the elderly people and disabilities and the poor. Okay, why she said that? She ended by exhorting the audience to value children as a citizen, not just of future, but also the present. So most inspiring quote she present, if we kill off idea from beginning, it limits our creativity and dampen the design process. At the end, she give the storytelling tips. When showing the photos to the audience, always describe them, the context, the image, or explain that they are looking at. For example, Manzar shows photos of park and explain what the audience are seeing. She explained that they implemented some of the ideas, such as improving access to creek for safe swimming for the kids, and the lightning underpass brightly so high school students would feel safe walking back to home at night. They provided thrill-seeking activity for adolescents. The way toddlers walk down a lane and expose their surroundings taught them to slow down and design a path where the journey was as important as the destination. So moral of this story, we have to be, when we are thinking about anything, we give importance to everyone, even little kid too. We are taking any kind of decision of our life, we should involve in our family. When we are in our family, we are in our workplace, we have to include everybody. We work as a team. So the key interesting takeaway from this story, she said a city friendly to children is a city friendly to all, because kids are inclusive. When they design, they think not just to themselves, but also of their grandparents and animals. Means once this is proved, like the city is safe for kids, so this city is safe for everybody, like for the kids, for grandparents, for animals, everybody. Then I have some pictures. When I read the topic of TED Talk, actually this topic is very huge, and just give me a very good idea. And some of the pictures I am presenting here, like how we, when we are talking, how we to be concise our topic, how we make our topic more more attentive, so audience give attention. So this is from TED Talk I learned. So content must be great. A brilliant presentation always start with wow content. Then the key to creating good content is actually simple. Your insight into them of the presentation is broad and deep. And just I mentioned before, like our talk should be less than 18 minutes, because the brain neuron have limit to absorb. And if we getting prolong it, and if we are talking more about that topic again and again, it will be removed from our brain finally. So then should be okay. Then you really master the topic you want to present and able to provide an interesting insight to the audience. Then presentation, content and style, storytelling. When we are presenting some topic, there's must be like a storytelling. The presentation is delivered through an evocative story, and then convey the lesson, like moral of the story. Fact and finding, then we have to present. The presentation is delivered by explaining facts, research, finding, and insightable data about a topic being discussed. Then choose the style. Choose the style of presentation, content that best suit the purpose of your presentation. Okay. And the slide should be designed with a good visual sensitivity. Like every sentences and image in the slide must be designed artistically. Like we have to put some pictures, some graphs to make it very beautiful. And if needed, and display attractive images prominently. Like here in this image is this is a beautiful car. And then ugly presentation make viewer sleepy. And our example of bad presentation showing in this slide, here's the mentioning a beautiful car behind, and in front are letters, but we are not able to see a car properly and letters properly. So, and write only the main points that you want to convey. Avoid displaying too long sentences and boring on a slide. Then a more interesting presentation design is that in which the content is defined and the slides are beautiful and the different colors are used so audience get attention. Then good pictures can be support the content of the presentation. Like this, they are showing, they are talking about some topic, but the one picture is explaining everything. Thank you so much. This is from my side.
Thank you so much, Dr. Mine, and thank you all. That presentation, well, great, all of that. Thank you. It's great. I know some of you might have an idea about TED Talks and the videos that are available online for everyone to look at. And some of them are very good as far as inspirations and what to do next, opening ideas, sharing new ideas, and also giving solutions to some of the problems. But it's very good if you want to look at some of these videos. I did my fellowship in Grand Rapids, and it's a city about 1 hour far from Lansing, where I live here. So in that city, they had a similar concept, but they said the title was 5 for 5. So that's for funding opportunity for the new ideas to bring business to Grand Rapids, the city. So they offer $5,000 for any person or group of people who can come up with an idea, but they can explain that idea in 5 minutes. So there is a competition. So it's like every month on one day, they come and they have, let's say, 5 spots. So spot number 1 will come and people will mention their idea. And in that 5 minutes, we'll try to solve a problem and improve the city. If they win out of these 5 teams, then the city will give them $5,000, and they will start like a startup process for a small company or something, which I thought it might be a good creative idea to solve issues. So TED Talk is a great tool if you want to look at it, watch some of the videos. Thanks for sharing, Dr. Mine. Any questions? Any comments? We had great presentations. So let me ask if you have any updates as far as your programs or your projects, your ideas. I know nowadays all of you are busy preparing for the RAS application and statement and recommendation letters and selecting the programs and so forth. But we don't want to or miss out, and also we need to prepare for the interviews. So in the coming weeks, we will work hard on getting some information about how to prepare, how to do mock interviews. And the more we do this, the more you will be prepared for the actual interviews. Hopefully all of you will get fun and hopefully all of you will match. Thanks. So anyone with any updates for next?
Yeah.
Yes, go ahead. Dr.
Yes, I submit the our manuscript like 3 days ago about the vitamin D affect diabetes at Curious Journal. So we are waiting to hear back from them.
Excellent. Congratulations for the submission and good luck for hopefully you'll hear good news.
Okay, thank you.
Anything else?
Hi, Dr. Nader.
Yes.
Hope you're doing good.
Good.
Well, regarding our study varicella and myocarditis, we had a meeting yesterday and we made the changes, and by tomorrow we're gonna further do some changes and edit the final draft and forward it to you. And we want your suggestions regarding the journal. We were planning of publishing it in Circulation or Basics in Cardiology Research and International Journal of Cardiology. And these were the things that we thought of. But in case you think something else would be a better choice, we would want to go for that. So yeah.
Sounds good. So thank you so much for the update. Yeah, when we submit the draft, I'll look at it and then these are good options, and we can think about other options as well. Okay.
Sure, Dr. Nader. Thank you.
Thank you so much for that. Excellent. And also just for the update tomorrow, we'll have the webinar in Arabic. Hopefully, if not all of you, most of you will attend. Posted for it. So it's going to be at 1 o'clock New York time. If you can also pass it to other interactive groups, that would be great. Any other updates? I know we have a couple of abstracts that have been accepted in 2 or 3 conferences, so we will be preparing for this presentation in the coming weeks. Any other suggestions or any other questions out of the project?
Assalamu alaikum, Dr. Nader.
Alaikum assalam wa rahmatullah. Go ahead.
I have question regarding ERAS application and program search. There is some program have 2, categorical and preliminary. So my question is, if I apply for both of them, is this gonna affect my chance to get categorical? Is it okay to apply for both of them, or the good idea is to apply just for categorical if you're looking for categorical?
I'll open this excellent question to the floor and see what other fellows think, and then I will update on. Anyone wants to jump and address this good question? So let me ask you, Dr. Ayman, what's the difference between them?
The difference is, yes, categorical that means you're gonna do regular one, like 3 years, and you're gonna be certified as resident, as physician right here in US. Preliminary that means they're gonna give you just 1 year, and after that you choose if you wanna continue with them or no, but there's no guarantee that they're gonna give you a chance to continue with them. So I asked someone, he mentioned like, if you apply for a job and you apply for to be a chief and apply to be an employee. If you apply for both of them, they're gonna say, hey, why we give him to be a chief? Let's give him to be just an employee. So this make me confused. Is it a good idea to apply for both of them at the same time, or just apply for the critical one? At the same time, I said I don't want to lose my chance. Maybe if I get chance to if I'm not gonna get any categorical, why? We will do first 1 year. So why I lost my chance at this area?
Excellent question, and thanks for the clarification. So here I'm going to give you my talk, and then I can apply the same concept. So I went through, I was interested in neurology, so I did some research work in neurology and some programs in that area. I was interested in one, and they said we can accept you, but you need to do the third year internship. So I applied to the primary program, and they needed someone, so they accepted me. So I did 1 year, and they know that I'm going second year to neurology program back in the college. So if they know that you are going to spend 1 year with them, and then you have another area of interest or another program lined up, you have a plan for yourself, then they will say, oh, you have a great plan for yourself, and you have this position only for 1 year, so we need you to cover that. So you, in your application, you can specify that, or in your session statement that you need 1 year as internal medicine in general, and then you go to the specialty of the area where you want to finish the other 2 or 3 years in your training. If, however, on the other side, if you are really interested in internal medicine and you want to continue for the internal medicine from the start to finish, like the 3 years, then the categorical option might be the best for you. So and in your statement, in your application, and in your setup the condition, you want to convince the program that you are interested in pursuing 3 years of training in internal medicine, for instance. So there are 2 options. If you want to do neurology or psych or something else, then you want only 1 year, and that will be the primary year. If you are really interested in the internal medicine, so you need to spend the 3 years, so you need to apply for the category. If you apply for both, yes, it will increase the chance as far as number-wise. So if the program coordinator is the same, and people who review the applications, the same group, then you will be wasting your time, because the 2 applications, if they choose you, they will look at you in one application or letters or statements will say, I want to spend 1 year here, and then I'm going to somewhere else. And in the other application, you say, I want to spend 3 years with you. So it doesn't make sense for them if they pick you. So I think you have to decide either way, 1 or 2, one of them. You don't combine them. You don't want to waste your time applying to 2 places, especially the coordinator for both programs is the same. Most likely the people who will review your application will be more or less the same, or the interviews. So your chance will be limited if they compare 2 applications for you. And one will say, I want to spend only 1 year because I'm going, let's say, in neurology. In another statement, you will say, oh, I want to stay with you for 2 years, and I'm interested in doing this, and then you just take your application out. If that makes sense.
Yeah, definitely. In my case, I wanna apply just for internal medicine, and when I search for this program, I put in the preliminary, my second year is going to be internal medicine. So by this way, did I increase my chance, or is it? I'm going back for the same question.
So if you say that in your primary, you can try, and I haven't heard about kicking out the application if it's due, because if they interest in you, then they want you to be there, whether you are staying for 1 year or for 6 years. So go ahead, yeah.
Okay, thank you so much.
Go ahead. Any other questions or suggestions?
Yes, Dr. Nadir.
Yes, go ahead.
Yes, Dr. Nadir, when we are going to searching in the programs, like when we for internal medicine, like there's a mentioned categorical and preliminary. So program director name is mentioning one, not different for both. So I think they both should be review our same application.
This is what I said. If it's the same program, they have two openings, one for preliminary, one for the categorical. Most likely, they will set the preliminary for people who are interested in somewhere else, and for the category for people who are interested in the program. So if you want to apply, I advise you to focus on the categorical and mention that in your application that you are interested in the program and the like 3 years. So if you want to be unique, if you are interested in geriatric, mention that as well. So it will be like you will mention, I want to finish the 3 years in your program and then I want to do geriatric, for instance. When they look at your application, they will say, oh, it's supported by the fellowship you are doing now. So that means you are really interested in our program and you are really interested in carrying on to finish your fellowship in geriatric, for instance.
Thank you so much, Dr. Nadir, for clarifying. Thank you.
So, good question. Any other questions? Telal, you mentioned in the chat something. Can you explain that?
Yeah, the problem is resolved for me because now it is okay. Thank you, Dr. Nadir.
Okay, thank you. All right. If there is no other questions, I'm gonna talk about next week's program or agenda. So we have the orange team will be working on the agenda listed in the app. If you have any questions, let me know. If some resources you can use it or you can do something. If for any reason you are not able to participate, please let the team leader know, and maybe other people who have some time they can contribute from upstream if there are not enough people to present. All right. Any other questions, comments, suggestions before we again? So thank you everyone for attending, and thanks to the presenters. You did a great job. And thank you, Dr. Maya, for moderating this team and Zoom meeting. And I'd like to wish you all the best for your application. Good luck. If you have questions, comments, ideas, or any suggestions, please email me. I'll be happy to discuss this. Thank you and good luck. Wishing you all the best. Assalamu alaikum.
Thank you so much.
Thank you so much.
Thank you, Dr. Nadir.
Goodbye.
Goodbye.
Thank you, Dr. Nadir.
Thank you, Dr.
Thank you, Dr. Nadir.
Thank you.
Thank you, Dr. Nadir.
Have a great day.
Thank you, Dr. Nadir. Have a great day.
Thank you. Have a great day.
Have a good one.
Thank you, Dr. Nadir.
Thank you.
Assalamu alaikum.
Alaikum assalam wa rahmatullah.
جزاك الله خير دكتور نادر. شكرا لك.
جزاكم الله خير.
Thank you very much.
Thank you.